Okay. Good afternoon and welcome to today's Environmental Nursing Conference titled Nursing Leadership in Climate Change and Environmental Health, presented by Jonas Nursing and Veterans Healthcare, a signature program of Jonas Philanthropies. I am Dr. Stephen Ferrara, the Interim Executive Director of the program, which is housed at the Columbia University School of Nursing. Our focus today is on climate change and environmental impacts on population health. We have nurse scientists who are experts in the field, sharing their insight and recommendations on how we can advance nursing leadership in the field of environmental health. Thank you to Columbia University's School of Nursing for providing CNE credits for our event today. An email link with further instructions will be sent to all attendees following today's conference. Columbia University School of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. Today, we will be using the Zoom webinar platform, which allows you to submit questions for our presenters through the Q&A tab through each presentation. We like to stay connected with our audience, so please be sure to follow us on social media and tag us on your posts with the hashtag JonasImpact. To kick things off, I am pleased to welcome Lendri Purcell, Vice President of Jonas Philanthropies and Environmental Health Lead, who will help set the stage for our event today. Welcome, Lendri.
On behalf of my grandfather, Donald Jonas, and the entire Jonas family and board of directors, I'm so happy to welcome you all here today to learn a subject that has been of great importance to me personally and in my philanthropic work. We are also grateful to my grandparents, Donald and Barbara Jonas, who started focusing their philanthropy 15 years ago on making an impact on the nursing sector to help address the nursing shortage by providing scholarships to nurse leaders seeking their doctorates. From there, Jonas Philanthropies' interests have grown to making an impact on all health, not just investing in the health of people, but in our planet as well. With a continued leading focus on our nursing and veterans healthcare program, as well as a renewed intensity on our vision and environmental health program, and our Trees for Climate Health program, Jonas Philanthropies is emerging as a leading health organization in these areas. How fortunate are we for moments such as today where we can combine our interest areas and showcase the ways in which nurse leaders are leading and translating research to benefit population health, especially where the environment and climate change are affecting human health. We know from research that climate change and other environmental stressors affect human health. We also know that not everyone is equally at risk and multiple factors impact our environmental health. I know you've had an opportunity to read up on the expertise of our speakers and presenters, and you will also hear some brief introductory bios when they are introduced. We are so pleased to have such talent on today's roster and so fortunate to have some of the nation's leading nurse leaders who are subject matter experts on environment and climate health factors present to us today. We will hear from today's experts about air pollution impacts on maternal and fetal health, the climate crisis impact on people during COVID-19, environmental impacts and their role in healthcare inequities, and service-related environmental hazards on veterans' health. Today's half-day conference is robust and will showcase nurse-led thought leadership in one of the most important areas Jonas Philanthropies seeks to make a difference. I thank you all for being here today as participants and to our esteemed panelists and speakers. I know that with all of us a part of today's conversation, we can all contribute to resolving important health and environmental factors. I will now turn it back to the team and look forward to learning along with all of you today.
Hi, everyone, and thank you, Lendri. I am Dr. Althea Hicks, Grants and Programs Manager here at Jonas Nursing and Veterans Healthcare, And I am pleased to welcome our first presenter for today, Annabelle Castro Thompson. Ms. Thompson is Senior Vice President of Health Equity at Equality Health. Working closely with key stakeholders in the community, Ms. Castro Thompson has pioneered an innovative, replicable, and sustainable cultural care model that establishes Equality Health as a trusted resource among patients and providers alike. A fellow of the American Academy of Nursing and the American Association of Nurse Practitioners, Ms. Castro Thompson's leadership exemplifies sustained commitment towards improving healthcare for Latino and underserved communities. Determined to bridge healthcare disparities, she is responsible for building and managing innovative programs and strategic initiatives which improve engagement, outcomes, and decrease costs. Annabelle is passionate about principles of environmental justice and climate equity. A 20-year healthcare veteran and Latino advocate, she is a past president of the National Association of Hispanic Nurses, otherwise known as NAHN, and serves on multiple national boards, including the Alliance of Nurses for Healthy Environments, also known as ANNE, Eco America Health Leadership Circle, and the Latina Strong Foundation. Ms. Castro Thompson is also the recipient of numerous awards and was a participant in Jane Fonda's Fire Drills Fridays Climate and Health Session in December 2019. She has been honored as a distinguished alumni by both her alma maters, the University of Arizona and Arizona State University. Ms. Castro Thompson will present on climate change and health inequity. Please welcome Ms. Annabelle Castro Thompson. Thank you for being here today.
Thank you, Dr. Hicks, for the invitation. I'd also like to thank the Conference Planning Committee for the opportunity to be here. And I'll go ahead and share my screen. Okay, excellent. I hope you can see it. As Dr. Hicks mentioned, I'll be speaking today about climate change and health inequities. And before I do that, I'd like to just make a few remarks. For those of us who have been working in the field of health equity for many years now, it has been sobering to witness the disproportionate impact of COVID-19 on disenfranchised communities and individuals. Due to ongoing social, economic, and healthcare inequities, communities of color have suffered higher rates of COVID infection, higher mortality rates, and most recently, far lower rates of COVID immunization. In this manner, COVID has placed the interconnectedness issues of health equities and health disparities in clear relief as an ongoing challenge not only to society generally, but also healthcare and public health more specifically. If we had achieved health equity in this country, then both the burden of disease and benefits of treatment and vaccination would have been more equitably shared. That said, like all of you, I look forward to returning to normality by this fall as we work towards herd immunity. It may be a bit of a new normal, but it will resemble life before COVID. For me personally, I look forward to attending meetings and conferences in person. Importantly, a return to normality includes an opportunity to refocus on critically important non-COVID health issues, which have been largely neglected during the pandemic. These issues include opioid use disorder, childhood immunizations, cancer screenings, and mental health. In particular, as a society, we need to place a laser-like focus back on climate change, probably the most urgent and significant health issue we will be facing in the next several decades. Apologies about this. I am wanting to move my, okay, got it. As I will discuss, Climate change disproportionately impacts low-income communities of color and other disenfranchised groups. Remediating the impact of climate change is therefore a moral imperative, as well as a societal, economic, and public health challenge. Scientific observations in climate model results indicate that the Earth's atmosphere is warming due to human activities such as the burning of fossil fuels, coal, gas, and oil, as well as animal production and electricity production, among others. Climate change threatens our life support systems and sustainability. Humans cannot live without clean air, water, food, and shelter. Due to long-lived CO2 in the atmosphere, the reality is that certain climate impacts are inevitable. This slide indicates the impact of climate change we are already seeing in this country. This includes rising temperatures, wildfires, heat waves, droughts, floods, and hurricane. This slide shows how different regions of the country experience climate change differently. In parts of the Gulf Coast, we are already seeing the sea level rise. Less than a month ago, Tennessee saw a record amount of rainfall resulting in deadly floods. In the Southwest, which is my home, in the last decade, we have experienced the most persistent drought on record. Water supply from the Colorado River is shared by 7 states, and the lower basin water supply is shared by 3 states, Arizona, California, Nevada. Arizona and Nevada are both seeing explosive population growth despite our water shortages and concerns. Uranium mining at the Grand Canyon threatens our water supply. Nearly every heat record in Phoenix, Arizona was broken in 2020. We had over 35 days of record-breaking heat over 105 degrees. In addition, we have a troubling statistic of lack of rainfall. In 2020, we had fewer rainy days and longer periods of droughts. This slide details weather and climate disasters just in 2020. We saw a record smashing 22 weather or climate disasters that each resulted in at least 1 billion in damages, including a record-setting 7 linked to landfalling hurricanes and tropical storms. Fortunately, by no means is it too late to impact climate change. The amount of future climate change will largely be determined by choices society makes about green gas emissions. Lower emissions in heat-trapping gases and particles means less future warming and less severe impacts. Higher emissions means more warming and more severe impacts. Cutting carbon emissions is the only long-term solution for avoiding climate impacts. Recycling and driving more fuel-efficient cars are examples of important behavioral changes that will help, but will not be enough. Indeed, to achieve net zero CO2 emissions, we need a massive transformation. The scale of change also requires a significant international cooperation, and the Paris Agreement reflects the world's best effort to date to collectively solve climate change, though it doesn't include the emission reductions we need. In short, we need to adapt. That means everything from discouraging development in high-risk areas, to planning for water scarcity, to building more resilient cities and communities, and investments should be scientifically sound and socially just and focused where the impacts are the greatest. That means often in low-income communities and communities of color. This is a busy slide, but what you can see at the top is the direct impact on climate change, such as rising temperatures, extreme weather, air quality impacts, and vector-borne diseases. At the bottom is the health outcomes associated with these conditions: heat stroke, dehydration, cardiovascular disease, respiratory disease, injury, waterborne illnesses, increases in allergy-related illnesses, and increased cases of vector-borne diseases, such as Lyme disease and West Nile disease. This graph reflects what many of us here in the conference have come to know and understand, that climate change is a health issue and that climate action is healthcare. The impact of human health. Due to climate change over the coming decades, we expect to see a substantial increase in illness and death due to heat-related illnesses. The slide shows us that from 1980 to 2013, there were 2.5 million deaths globally due to climate-related disasters. The World Health Organization estimates that climate change will cause an additional 250,000 deaths per year between 2030 and 2050, and 99% of the impact of disease burden will occur in developing countries, with 88% of that affecting children under the age of 5 years old. So indeed, fundamentally unjust. Not everyone, however, is at equal risk of harm due to climate change. Risk varies depending on location of residence, current health status, occupation, access to care, the social determinants of health, among other factors. Examples of at-risk communities and populations include people that live in low-lying coastal communities are at greater risk of coastal flood from sea level rise and tidal storm surges. People living in floodplains. Communities on or below steep hillsides are at risk of mudslides, landslides during extreme weather events. Those living at the wilderness-urban interface are at highest risk for wildfires. Outdoor workers such as agricultural, landscape, and construction workers are at risk due to extreme heat. First responders are at risk of death and injury during extreme events such as hurricanes and wildfires. Older adults and children have increased susceptibility to heat stress. Individuals with pre-existing climate-sensitive conditions such as asthma and COPD are at greater risk of respiratory illness from increased ozone, wildfire smoke, or increased pollen. And people with obesity, diabetes, cardiovascular disease, and mental illness are more susceptible to heat impacts. In the US, the health of low-income populations and communities of colors is more likely to be impacted by climate change for a number of reasons. Low-income populations and communities of color are more likely to live in areas with less green space and to be more vulnerable to heat-related and respiratory illnesses. These communities have reduced access to key information and available programs and services as a result of language, culture, or geographical barriers. For example, community members may be unaware of the existence of resources such as cooling centers that may be open during heat waves due to materials not being translated or perhaps available in the traditional places that they access community information. Vulnerable communities are more likely to suffer from lack of food and medicine during disasters, just as they are least likely to have air conditioner during heat waves and a car to carry them to safety. Low-income populations in communities of color are more likely to reside in substandard housing, often in crowded conditions. Substandard or deteriorating water infrastructure, including sewerage, drainage, stormwater systems, and drinking water systems in both urban and rural income areas, also contribute to increased risk of exposure to waterborne pathogens. Extreme heat and water events and drought contribute to declining in crops yields and a reduction in the nutrient in the protein content of some crops like wheat and rice. As crop production declines, food prices will increase, Low-income communities are more likely to be affected because they spend a relatively large portion of their household income on food compared to more affluent households. And they are also more likely to reside in areas considered food deserts. Furthermore, numerous studies show that those forced from their homes by disasters are at higher risk of developing mental health problems, and that the elevated stress levels they experience can lead to a variety of harms. High levels of stress hormone cortisol among pregnant women, we've known, can lead to negative health outcomes in their children. So in other words, the same physical, social, economic environments that are associated with poor health outcomes also increase exposure and vulnerability to the health impacts of climate change. These communities are often historically disenfranchised. They lack the political and economic power and voice to ensure that their decision makers take their perspectives, needs, and ideas fully into account. The lack of power contributes to health inequities and constrains their ability to build climate resilience and to fully contribute to climate change solutions. So let's briefly examine the impact on climate change on specific communities. African American communities have lower income, less education, and poorer health status than non-Hispanic white communities overall, largely due to the legacy of slavery and historical discrimination practices in housing, education, employment, and healthcare. These inequities contribute to greater vulnerability to climate impacts. You can see here that African Americans reside in inner city neighborhoods with fewer trees and more heat-trapping pavement. The rate of heat-related deaths in African Americans is 150 to 200% greater. And African Americans have a 36% higher rate of asthma and are 3 times more likely to die or visit the emergency room from asthma-related complications than non-Hispanic whites. Native Americans and Alaskan Natives. Historical policies such as colonization and genocide, the Indian Removal Act of 1830, and residential schools for Native American children have led to present-day social and health inequities, including loss of traditional lifestyles, persistent poverty, substandard health services, and lack of access to electricity, running water, and communication technologies. Traditional Native American and Alaskan Native diets and subsistence hunting and fishing are at risk due to climate change. These communities lack access to clean, potable drinking water at higher rates than others, and warmer temperatures may exacerbate already high rates of diarrhea association hospitalization that we see in their children. Historical practices such as colonization and trade have led to present-day social and health inequities that increase climate-related risks in Native Hawaiian and Pacific Islander communities. Scientists project that by 2100, Hawaii and some of the Pacific Islands will experience 1 to 2.5 feet sea level rise. A higher proportion of this population lives in counties with pollution exceeding the federal air quality standards, and these communities experience higher rates of asthma. Latino communities have lower income, less education, and poorer health status than non-Hispanic white communities overall, largely due to historical discrimination practices in housing, education, employment, and healthcare. Most Latinos live in southwestern states that have been affected by drought and wildfires. Latinos are more likely to live in risk-prone areas such as urban heatlands, coastal, and other flood-prone areas, and areas with increased burden of air pollution. 1 of every 2 Latinos in the United States live in counties considered the most polluted cities as designated by the CDC. Latino children are twice as likely to die from asthma and to live in areas with high levels of air pollution, which give them heightened risk for developing type 2 diabetes. More than 1.8 million Latinos live within half-a-mile radius of oil and gas development, and an additional 39% live within 30 miles of power plants. Latinos are more likely to suffer the effects of heat stress disproportionately because they work in agricultural, construction, and landscaping sectors. Latinos are 3 times more likely to suffer heat-related death among agricultural workers, and almost twice as likely to suffer heat-related death among construction workers. There's also increased risk from occupational carbon monoxide exposure among Latinos. It is hard then to overstate the connection between climate change, social and health equity, and health disparities. As we can see in this framework for action, a more fair, a more equitable, and a more effective approach towards remediating the impacts of climate change begins with empowerment, collaboration, and advocacy. Effective actions in this regard addresses the root problem of climate change and resulting health disparities, such as the social and structural inequities related to housing, transportation, employment, and food security. Public policy that involves improving living conditions for low-income communities by nature will improve climate resilience among these communities and decrease health disparities. Therefore, reducing the impact of climate change among poor and vulnerable populations will require the involvement of many sectors, including government, industry, education, research, and community-based organizations, to name a few. And they will have to act in a coordinated fashion. In reaching out to affected communities regarding remediation and/or adaptation strategies, it is important for education and messaging to account for trauma, historical trauma, cultural differences, linguistic access, and limitation in personal financial resources. In my last few minutes, I want to touch upon what we as community members and as healthcare professionals can do to mitigate climate change impact among vulnerable communities. So there are many contributions we can do at many levels. At an individual level, we must support elected officials who support efforts to address climate change. We should increase household energy efficiency through individual efforts. Initial efforts should always start at home, and we should volunteer with agencies that educate about climate change and advocate for systems, policies, and programs that address climate change. I am a big proponent that if you don't like what you see in your community, then volunteer and make a difference. As healthcare professionals, I've learned over time that health professionals' source of power is collective action, and that we need to seek allies and that we need to engage. As healthcare professionals, we can also promote climate literacy among healthcare workers, providers, and administrators. We can provide culturally competent care in line with the national standards for culturally and linguistic appropriate services class. We should also build information and education that talks to the value and preferences of specific communities, and we should incorporate these in crafting messages. So for example, when we talk to Latino communities, we should expand on familismo and the importance of family and how everyone needs to engage so that we can leave children a better future in a better planet. We should promote health literacy among minority and vulnerable populations to encourage both utilization of acute care services related to climate-induced conditions and during emergencies, but also utilization of preventive services for disease screening and detection, for chronic disease management, and for general wellness. We should support patient access to the social determinants of health during the delivery of physical and behavioral health services. We should develop organizational plans to minimize healthcare facilities' carbon footprints in activities including but not limited to transportation, food services, local sourcing, waste management, energy, and water conservation practices. And we must work closely with public health and other agencies in emergency preparedness planning so that vulnerable populations can better access care and support services during emergency circumstances. In summary, climate change, equity, and health disparities are intimately interconnected. The individuals and communities least responsible are the ones most negatively impacted by climate change. Efforts to improve health, social, economic, and racial ethnic equity will go a long ways towards improving climate resilience among vulnerable populations and alleviating health disparities. And then there's a role for virtually every person in the planet in remediating climate change. We must act now. I do think we have much to do, and I look forward to working with all of you in this most worthwhile endeavor. Thank you.
That was a great presentation. Thank you so much, Ms. Castro-Thompson, for sharing all of that information with us. It was very informative and very detailed. And of course, you went through all the different populations and different locations throughout the country. So, this is definitely something that many of our people in our audience can probably relate to, depending on wherever they are. We do have a few questions for you. So just like to go through them and feel free to share, any additional information that you think might be helpful for some of these questions. Our first question is, what are some of the leading areas of nursing that feature nursing students or nurse scientists, future nursing students or nurse scientists can specialize in to address some of the disparities? For example, urban health or rural health. And is it common to have joint public health degrees?
Dr. Hicks, that's a great question. I've seen a lot of my nursing college who possess public health degrees, and they're very beneficial in the way that they view the environment and the impact of health and climate change on healthcare, and it's certainly beneficial. However, there are many of us too who don't have the public health perspective, but understand fully that in order to impact communities, you need the community view, you need the global view, and you need to understand that climate change and environment is synonymous or significant in addressing healthcare. I would say that for anyone that's interested in this type of work, I've seen a lot of my colleagues go into community health. Certainly a lot of my colleagues are in public health. But there's also areas such as executive leadership. I know a lot of my colleagues in sustainability efforts in their healthcare systems who do this type of work. I think more and more healthcare is waking up to the realization that climate change and the impacts of health have to be incorporated in healthcare. And more, I'm seeing my colleagues in nursing and in other health professions engage on the subject.
Well, thank you. That's good to know because, I think that's one of the things people don't realize with the different populations and the different areas of health, that you can be, as you mentioned, in leadership and, work in advocacy for environmental health, or you can be in public health, you can be in the community, you can be in different areas and still volunteer or work or contribute to make a difference in the community. And one of the things for the questions that also came up was actually, where do you start? And I'm thinking of this maybe, of course, maybe with students, and then also those who may be working more clinical areas, like in hospitals or a private office, just knowing like, well, where do you actually get started participating in something like this?
Sure. So for the people in the audience, there's several pathways that you can follow into getting in this kind of work. If you are doing rotations, if you are in a community setting, if you are in a hospital setting, I would say start asking around as to who does sustainability efforts in the agency, who does recycling efforts, who is looking into the social determinants of health. Environmental justice right now is a hot topic, and it's part of the social determinants of health. And so there will be somebody in any agency who is doing this work. And I'll give you a quick example. So I work for an agency who works with ACOs and healthcare systems in engaging populations differently. My role is in the social determinants of health and cultural care models. Within the social determinants of health, one of the important things I laser focus us on is community design and environment, right? Because this is going to impact the health of communities. And I'll give you a quick example. We've noticed that Latinos living around areas of high concentration traffic or industry pollution, right, have higher rates of asthma. And so we've mobilized and we've put together efforts that build on public health so that we can start engaging in addressing the health of populations from a higher perspective, not just in how we meet their physical health needs, but how we can work in the environment to make sure that we make a difference. And so look for people like that. Within my department, I am housing a few initiatives so that we can make a difference in our community, such as downtown partnership efforts or trip reduction programs, which look into sustainable ways as to how do people are getting into work. I will say one last thing. There are plenty of nursing organizations that have a deep interest in climate change, in climate equity, and in environmental justice. And so these are also great starters for many people that want to engage in the subject. In particular, I can think of a few, certainly the Alliance of Nurses for Healthy Environments, the American Public Health Association. We certainly have a nursing public health association as well. And so there are many voices and many in the community who care about this conversation, and there's a lot of opportunities to engage.
Thank you. That's very helpful. I think that was another question that came up in regards to, you mentioned the clean air in industrial and urban communities. And I think that's a big challenge a lot of people experience. How do you actually contribute to advocating for clean air, in those communities, especially when you're dealing with so many factors, for example, like you said, traffic pollution or industrial pollution. And so you mentioned working with different community organizations. And of course, if you're at a hospital or something, you can find out who's doing work in sustainability or environmental justice or those different areas. And then that will help work as a collaborative so that I think, the nurses and healthcare workers don't have to feel like they have to work as individuals to try to get this done, because this is definitely something that would be a large undertaking. So That's very helpful. Another question that came up has been about masks. We've gone through, so we're still in it, but the pandemic and all of that, we've been wearing masks all this time. And do you know if there's any data to show or any studies or anything, basically if the masks have had an impact on some of these environmental issues, for example, the asthma you mentioned, maybe asthma rates or hospitalizations, maybe the reduction in pollution or anything like that, in terms of the impact of experiencing these environmental hazards. Do you know if there's any data on that from wearing the masks over the past year?
Not from wearing the mask, Dr. Hicks. I think one of the things that we saw initially in 2020 is the reduction of travel, right? In the reduction of traffic, which caused for pollution, and the reduction of human activity, which caused for pollution to go down. However, one of the things that we're having difficulty, for example, in Arizona where I live, we've noticed that 16% of Latino population have a diagnosis of asthma. When we've mapped the incidence and prevalence, we notice that these kids are living within areas of high concentration in air pollution, right? One of the things that we're seeing in 2020 is that ER admissions went down. However, I don't think necessarily there might be a related factor that pollution was down to a certain extent and that caused, right? Less admissions into the hospital. However, we also know that people were very scared to attend and go to the ER and the emergency room, and that oftentimes much of our population was not going to screenings and to doctor appointments. And so we don't have the evidence yet to know whether COVID in some way has impacted what we're seeing in low-income communities and communities of color. I'm not sure the mask, and some of my colleagues that will be speaking later on, it does much to control the particle pollution that we're seeing in some of our cities, which have been drafted as from the CDC as highly pollutant. But I do think that 2020 and the reduction of human activity, we saw a difference there.
That's good to know, because I think, a lot of people, initially you just think it's the masks, oh, we're wearing masks, it's, healthy. But, it makes sense, the reduction in activity, and of course, less trucks, less pollution, that would make sense in terms of impacting the health. And I have one more question for you before we wrap up today for this session. You mentioned health literacy. And so one question that arose is, how can we address language barriers with some populations to educate and promote health literacy around environmental health? Is there any suggestions or tips you can provide for that?
Yes. Through my work with many associations and organizations that are moving in this space, I've noticed that we're doing a really good job of engaging academics, and we're doing a really good job of engaging healthcare professionals. I do think that we need to work on engaging the community. When I go into the community by doing grassroots events or participating in community events, I notice that there's a high sense of climate anxiety. People want to know what to do, but we haven't given them practical, tangible information as to how they too can be involved. A lot of people hear about, oh, we should get solar panels and we should transition our vehicles, right, to electric. But many people in particular low-income communities and communities of color might not be able to take those big steps. And so we do need to do a better job of both drafting information in people's language so that they know how to work in this space and how they can participate and be part of the solution. I also think that we need to give people solutions that are within their financial capabilities so that they can start to participate. There are many things that we can do from a recycling sustainability, right? And how we engage going to work to reduce CO2 emissions. And then lastly, we need to start doing a lot in the work of class, right? Make sure that we are using the right language, that we're using the right literacy level, and that we're talking to communities from the values and the preferences that they see from a cultural standpoint so that they can join us in this movement. I mentioned briefly, Dr. Hicks, during my presentation that in Latino communities, if you frame it from the family perspective, right, Latino communities will engage. Native American communities care deeply about Mother Earth. And so we really have to ensure that our engagement, our collaterals, our materials are coming at them from places that they care deeply from. And so there's a lot of work that we can do. I would say for anyone that's on this conference that as nurses, we understand the community participatory approach. We are experts in educating and in advocating for our communities. We know how to do grassroots events. So it's a wonderful opportunity for us to participate and volunteer with organizations and associations that are trying to take this message to communities.
Well, that's wonderful. Thank you so much for all of this helpful information. I'm sure this has been very helpful for our audience. And you've mentioned so many different factors, including even the cultural competency. I think that's important as well in dealing with health inequities. So we appreciate your time today. We thank you for pulling together such a wonderful presentation for our audience. And now we'll wrap up this presentation and we'll take a 5-minute break for everyone. You can feel free to just step away for a few minutes and we'll be right back with our panel presentation. Thank you, everyone. Hi, everyone. Welcome back. Thank you all for joining us today. So now we'll move forward with our next presentation, a leadership and advocacy panel focused on environmental health and how nurses can play a role in climate change. Our moderator today is Dr. Laura Anderko, professor at Georgetown University's School of Nursing and Health Studies, where she holds the Robert and Kathleen Scanlon Endowed Chair in Values-Based Healthcare. She is the PI of the federally funded Region 3 Pediatric Environmental Health Specialty Unit and the Mid-Atlantic Center for Children's Health and the environment serving Pennsylvania, Virginia, West Virginia, Delaware, Maryland, and Washington, D.C. The Mid-Atlantic Center provides outreach, education to health providers and communities, as well as consultation and referrals related to reproductive and children's environmental health. A scholar and educator in the field of public health and environmental health, she has studied and published on the environmental health hazards such as perfluoroalkyl substances, also known as PFAS, impacting military communities. And she has served on a wide range of boards and committees, including several federal advisory committees, EPA's Children's Health Protection Advisory Committee, the Drinking Water Advisory Committee, and the National Environmental Justice Advisory Council. In 2013, she was recognized by the Obama White House as a champion of change for her advocacy efforts in climate change and public health. Welcome, Laura. Our first panelist is Elizabeth, also known as Beth Schenk, Executive Director of Environmental Stewardship, Providence Health System. Beth Schenk has been committed to decreasing the environmental impacts of healthcare for almost 30 years. As a nurse at the bedside, she saw many opportunities for improvement, which led to her decades-long commitment to environmental stewardship. Through conservation of resources, by improving practices and processes, and through education and research, she has helped drive improvements in Providence and serves as its Executive Director of Environmental Stewardship, leading the organization toward its goal of becoming carbon negative by 2030. Beth is an assistant research professor at Washington State University College of Nursing. She developed the Nurses Environmental Awareness Tool, measuring nurses' awareness and behaviors related to healthcare pollution. Additionally, she led the development of the CHANT Climate, Health, and Nursing tool, measuring health professionals' awareness and engagement with climate change and health. CHANT has been translated to several languages and used in over 30 nations. She developed the We Act framework, waste, energy, water, agriculture, food, chemicals, and transportation, to provide an easy-to-follow guide for caregivers to use at work and at home. And Beth is an active national, state, and local level. She's active on all those levels, serving on the national board of the Alliance for Nurses for Healthy Environments, also known as ANNIE, as treasurer of Montana Health Professionals for a Healthy Climate, and as board chair of Climate Smart Missoula. She hosts the Nurses for Healthy Environments podcast. She has been honored with the Charlotte Brody Award as a distinguished alumnus from the University of Montana and as a fellow in the American Academy of Nursing. Welcome, Beth.
Thank you.
And our second panelist today is Shanda Demarest, Strategic Sustainability Specialist with the Practice Green Health, where she works with hospitals and health systems to reduce their environmental impact. Dr. Demarest earned her doctorate of nursing practice and health innovation and leadership from the University of Minnesota. She also holds the LEED Green Associate credential through the U.S. Green Building Council. A cardiovascular nurse with horticultural training by background, Shanda leads the Nurses Climate Challenge at Healthcare Without Harm, a national campaign to educate 50,000 health professionals about the health impacts of climate change. She served on the executive board of Health Professionals for a Healthy Climate for 4 years and currently sits on the Global Climate Change Committee for the Alliance of Nurses for Healthy Environments. Shanda serves on the development team of the Nurses Drawdown, a global project to equip nurses to take climate action in accordance with Project Drawdown Solutions. Additionally, she is the co-PI in the development of CHANT, Climate Health and Nursing Tool, which measures nurses' awareness and engagement with climate change globally. Shanda also serves as an affiliate faculty member at the University of Minnesota School of Nursing and has published works on environmental sustainability in healthcare and the health impacts of climate change in local, state, and national journals. Welcome, Shanda.
Thank you, Dr. Hicks.
Thank you. We thank you all for being here with us today. And now I turn it over to our panelists. Welcome, Laura, Beth, and Shanda.
We've got some foundational documents that really spurred nursing to become a leader in the space of climate change and health. And way back in 1995, there was a document created out of the Institute of Medicine called Nursing Health and the Environment. Lillian Mood was a nurse on this committee that really set forth direction around education, practice, research, and advocacy. Next slide, please. And in addition to that document are the Nursing Social Policy Statement, the Code of Ethics, Nursing Scope and Standards of Practice that specifically requires environmental health to be a part of the practice, the standard practice of all nurses who graduate. And so as we lead into our conversation and our discussion about the great work of Beth and Shanda, keep in mind that fundamentally, we are required as nurses to consider environmental health within our practice. I will quickly tell you my story, which began as a home health nurse. I was making a home visit to a client, young woman, 18, who had just had a baby. And her baby was born without a brain. And so I was going in to do an exposure assessment just to sort of see what was going on. Was mom on drugs? Did she eat well? She had done everything right. She wasn't taking drugs. She took her prenatal vitamins. And then when I left, I realized that this little house was nestled within a lot of factories and pollution. And it began my journey to reach out to folks nurses across the country to learn more about what might have been the cause of that baby's demise. And then really began my journey to explore all things environment as it impacts people's health. So with that, I'm going to hand it over to Beth, who is going to tell us a little bit about her work and her leadership innovations.
All right. Thank you, Laura. And I am getting to, I believe, the slides. Can you see? Sorry. Now do you see the blue slide with my name? Yes.
Yes.
Okay. Well, thank you. Well, we were asked each to talk a little bit about why we're doing this work. And you just heard Laura explain her background. You heard with Dr. Hicks talking about the introductions to each of us, much of my work, my professional work. But I have to say that this slide rather captures really what my obsession is about this. And what I mean by this is really our environmental crisis, our socio-environmental crisis. I feel like it's the dominant theme in my life. Certainly, I feel that it's the dominant issue of our day, and therefore I am called to act on it. I also feel like in healthcare is on the wrong side of the equation here because we are polluting, and that pollution drives toward disease. That's not what we want to be doing. And I recognized that early on in my nursing career. I also recognize that nurses are key to the solution. So I've been pushing on that for a long time. I still believe it. I am committed to um, further the profession. So I'm really grateful for this opportunity to speak with you all today, because nurses are in optimal positions. We understand healthcare. We know how it works. We are operators. We can fix things. We understand the complexity of some of the issues in healthcare itself for healthcare pollution. So I would say it's really hard to solve healthcare pollution without engaging nurses. Now, nurses don't have reach and access to every single issue, but really to a lot of them, including overuse of resources, the waste that's created with that, consumer use of electricity in healthcare, exposures to chemicals, and others. So I work through a number of those issues in my professional work. So I feel like this slide kind of captures where we are in time, and that really this is up to us. It's up to us in healthcare, and it's up to us in nursing to change our own profession, knowing that our profession is the largest one in the world in healthcare, largest in the United States, most trusted voice. Lots of reasons why nurses can, and in my opinion, should be engaged in this work. So that's a little bit of my background. Now, Laura, do you want to ask me questions, or do you want me to kind of keep talking? What would you prefer?
I do have a question for you, Beth. Can you hear
Okay.
me okay?
I can, thank you.
Yeah, so one of the things that that is impressive about your work is that you have led environmental stewardship in a healthcare system, a large healthcare system with over 40,000 nurses. How do you approach this in a complex organization? How does this happen?
Well, thank you, Laura. And I do have some comments about that. You know, when I started as a direct care nurse, it was often seeing with frustration how much waste we created. That led to many years of kind of figuring out more about how healthcare worked, what departments and individuals could do something about it, how to advocate in a way that was effective and not off-putting in my requests, but also persistent. So I think there's a lot to your question, and I'm just going to tell you a little bit about the organization. This is Providence Health. It's the third largest nonprofit in the United States. It's in 7 Western states. As you can see here, 51 hospitals, over 1,000 clinics. It's very large, an immense footprint. And as Dr. Hicks said in the introduction, we committed to become carbon negative by 2030. And this happened a year ago last week. It was on the 50th anniversary of Earth Day, so Earth Day of 2020. And what that means is that we are going to go beyond addressing our own carbon emissions to removing more from the atmosphere than we actually put in. Further, what we have taken on is all 3 scopes of emissions. So if any of the listeners know about greenhouse gas accounting or carbon accounting, there are 3 different scopes. And this is the broadest definition of carbon emissions, including all of our supply chain, all of our business travel, employee travel, our investments, the whole work. So it's not just the energy that we use in our operations. So this is an enormous lift, honestly. And many, many people are working on it. And luckily, our leadership in our health system is behind this and supportive. Our facilities folks, including engineers, are behind it. Our IS people are really working hard on this. And that's a key driver, I will admit. And we will soon be starting what we're calling a clinical collaborative. So it's really to engage clinicians. That's kind of hard. I mean, I'm a nurse. I totally understand why we need to do that, but clinicians are busy. They have key priorities. It's hard to wrangle. Also, we have about 80,000 clinicians. So it is an immense task, but I think that is the game changer and the key element for healthcare, because it's clinicians who know what is needed in practice. So as mentioned, also, I developed this We Act framework and published on that a few years ago. And this is helpful, I think, for a few reasons. It consolidates the areas that we want to focus on: waste, energy, water, ag, food, chemicals, and transportation. And also it reminds us, back to my slide, of, well, how are we going to make this decision in terms of kind of business as usual and really trying to reclaim a healthy planet? That depends on us as we act to do that. So that's a constant reminder. And this has really taken off, I would say. When I began this role over a year ago, this was, my work from before. I did not know that it would resonate well. I didn't expect necessarily it would or wouldn't, but it has. And so we are writing this as a way of organizing our work, reporting our work. We measure in these categories, and we continually ask people to get engaged. And so this is for all including nursing. Let's see, I think then that might go to my next question, Laura. Or I'm not sure if you want to go to Shanda next. You can let me know what you'd like to do.
Actually, the next question I was going to ask you actually was asked by one of the participants.
Okay.
Which really has to do with adding, how do you add climate change to an already full curriculum? And tell us a bit more about both the research and education you've done related to climate change in nursing.
Well, I am partially involved at a university, so I have not focused as much on curricula. However, in my doctoral work, I examined all of the coursework at Washington State University to see where could we inject environmental health information as well as climate information. So that is, I think, a practical way to do it in terms of relating climate when you're talking about respiratory system issues. But we need more than that as well, because the practice areas related to environmental health and climate change are not featured very frequently in nursing. We're getting more so that we're looking at the conceptual frameworks. We're looking at planetary health. We're looking at climate change as a scientific event. But we're not really taking that down to, well, what should nurses do about it? What can nurses do about it? How should our practice be impacted? So I think that is work to be done. There are some areas around the country who are addressing this. And so if any of you out there listening are faculty, I think this is a great opportunity, or doctoral students or graduate students, this is a great opportunity to consider what are the effective drivers of change in nursing practice and how would we measure it? Something that I've done is, as mentioned, develop this nurses environmental awareness tool. That is a way to measure what nurses are aware of so far. And then you could fill in the gaps basically with education. And this is available for use for anybody who would like to. Also, we mentioned that the climate health and nursing tool is really not only for nurses at this point, it's for all health professionals. And this is a tool that anybody can use. We have a method for you to use it so that we can also collect the data and analyze it in an ongoing way, because we're looking at change over time. And so this is something that can also be used. Many universities are using this to measure pre and post after a course or an experience or even a lecture. So that's another way in. Just another topic that I have been working on is again related to practice. And this is to see what do nurses have access to in their practice. So many of you have heard of nurse sensitive quality indicators. Those are the quality outcomes that we track that we think are more impacted by nursing practice. So falls, pressure ulcer injury, CAUTI, urinary tract infection, bloodstream infection, and there are a few others, medication error. And so I've been thinking over time that, well, I think some of these aspects of environmental health in acute care are also sensitive to nursing. So we've been interviewing people from around the country and are analyzing that data now to see what is it of the We Act framework, particularly, that nurses have access to more than others. So it might make sense that nurses don't have that much access to renewable energy. They have some, they can advocate for it, but they're not the people installing that. They do have tremendous access to waste reduction, things like that. So that's an example, I think, of not so much curriculum, but of changing practice. Hope that's helpful.
Thanks, Beth. And so next we transition to Shanda, and who might also be able to answer that question about curriculum in universities. I know you're doing some work along those lines, as well as other things. So take it away, Shanda.
Absolutely. Hello there, everybody. Delighted to join you. I'm just going to throw a couple slides up. Laura, I think the I'd love to dig a little bit deeper into the curriculum question probably first, but since you both opened up with a little bit of a story, maybe I can go in that direction as well. I grew up in a rural community in Minnesota, right on the bluffs of the Mississippi River and with the coulees and the river valley, and nature was just integrated into the way that I saw the world. And, you know, we've heard both Beth and Laura talk about, you know, what our reality is as practicing nurses and what it looks like, feels like to be operating in such a resource intensive, energy consumptive, waste productive environment. And that was directly in conflict with the way that the way I was raised. And so I remember being a young nurse and just thinking about, or even Googling, where can a nurse work in the environment? Where can a nurse do sustainability work? And just reflecting about some of the history that Laura and Beth have shared so far, what's really striking to me is back in, the early 2010s, I thought there weren't nurses doing this work. And so frequently now, students will reach out to me, practicing nurses will reach out to me 10 years later and say, is anybody doing this work? And I think we're getting close to a tipping point where there's enough momentum so that healthcare generally is being much more mindful of environmental sustainability. Nurses are coming to the table for environmental and climate advocacy. But we need to break out of that model of, am I the only nurse doing this work? Because I think that by being much more inclusive of this in our curriculum and in our education and clinical settings and in the way that we practice, that's how we work towards that culture shift. So maybe to that first question, Laura, I'd like to pull up something called the Nurses Climate Challenge. And so this is a national initiative co-sponsored by ANNE, Alliance of Nurses for Healthy Environments, and Healthcare Without Harm, that is all about educating health professionals about those health impacts of climate change. And over time, we started to see nurses registering for access to resources, and these nurses were faculty. And basically, we learned that a lot of faculty members were using Nurses Climate Challenge content to educate their students. And that led us to develop something called the School of Nursing Commitment. And so basically, the esteemed faculty on the call today, Laura and Beth, helped us build this, among a few other faculty content experts across the country. And we developed basically a campaign to bring nursing schools together to develop a community of practice. And these faculty are using Nurses Climate Challenge resources to educate their students about not only how climate change impacts the health of patients and communities, but how to start to take action. And to that question of, how do you work this into a very jam-packed curriculum? I like the way, Beth, you were getting at this. I mean, the same way that we would integrate something into a spiraled curriculum. How do you address substance abuse? How do you address veteran-specific care? How do you address, X, Y, Z? What are those different opportunities within your curriculum map where it's already applicable? So we heard respiratory health, for instance. What about policy? Does your school have a policy course? What about community health? Could you integrate climate change and planetary health more broadly into a community health needs assessment? We heard Laura talk a little bit about what that could look like in a home care environment. Could we integrate this into nursing leadership? What could sustainability look like in a hospital if nursing steps up to the table? Could it be integrated in pediatrics, adult acute care, whether it's population-based, whether it's content-based, whether it's practice or theoretical? We have schools in the Nurses Climate Challenge that are really actualizing this. And we have almost 30 schools of nursing across the country, from anywhere from small private state colleges up to very large academic medical centers. And so I'd encourage you to investigate this. But whether or not you're thinking about climate as part of the curriculum through the Nurses Climate Challenge, my suggestion is to really be applying this in the same way that other cross-cutting curricular topics are integrated. How can it be spiraled up? And how can it be framed for faculty in a way that they see it as part of their courses that they're working hard on already?
Thanks, Shanda. There was a comment in the box that the Alliance of Nurses for Healthy Environments also has a curriculum related to climate change and health. And they're also coming out with a revised e-text that will help any faculty member or student interested in environmental health. Can you tell us a little bit about opportunities and organizations that can support nurses interested in climate and health, Shanda?
Absolutely. And to the comment about the Annie curricular recommendations for climate change as well, that's also currently undergoing revision and being very strategically integrated with the AACN Essentials. So a lot more to come on that. That'll add some robustness to all of this work happening. So yeah, Laura, to that question of, what are some orgs where nurses can learn more about climate and how to take action. I like this image from Healthcare Without Harm because it gives an idea of basically from a hospital, a typical tertiary healthcare delivery setting, where are those impacts of climate change? What contributes to greenhouse gases? And if you are a practicing health professional, you can start to see, what you are doing with your patients really does have that sometimes direct or indirect impact for greenhouse gas emissions. And Healthcare Without Harm, if it's not something that you're familiar with historically, it actually, at this point, is an international nonprofit that is all about not only sustainability in healthcare, but climate resilience and mitigation and advocacy across the sector. Historically, it was developed around mercury. So the history of Healthcare Without Harm is really fascinating in that it's very clinician driven. And, thinking about how we continue to build this momentum coming from nurses and other health professionals who start to identify, think way back, what are the health impacts of mercury in our water? What are the health impacts for a health system that's using mercury in thermometers and sphygmomanometers? Those direct tools that health professionals were using were contributing to, poisoning of lakes and streams and having those literal downstream effects. When we apply that same concept with climate, it starts to provide some clarity. How and why should health professionals care about this? So Healthcare Without Harm has both the nursing network that I've mentioned, the Nurses Climate Challenge. We also have a physician network that helps prepare clinicians to have these conversations with their hospital leadership. And best example at Providence is, I can say from experience at Practice Green Health, extremely cutting edge. And so we love to lift up stories like Providence and Kaiser Permanente and some of these organizations that are being bold and audacious about having, basically bringing their leadership up to speed. Healthcare tends to be 10 to 15 years kind of behind the 8 ball when it comes to environmental conservation and stewardship. So Healthcare Without Harm is a great resource for practicing clinicians and anyone in healthcare. And then I also want to make a nod to Practice Green Health, which is my primary organization that I work with. And you can see that these 11 strategic sustainability areas, they're actually not as siloed as they appear. We know that all of this is integrated and works very closely together. But at Practice Green Health, we have a network of around 1,200 hospitals that are committing to environmental sustainability and to reducing their environmental footprint. and carbon footprint, as we heard about Providence. And so basically we work across the spectrum to help these hospitals perform an assessment. You know, what's happening within your hospital? Are there sustainability initiatives? What are some of those baseline metrics that help hospitals understand what their environmental performance is based on KPIs and industry best practices? Then we help those systems put programming in place to seek improvement across programs. So whether it's waste reduction that we heard a little bit about, or chemicals, or even the food that's being served in hospitals. How far does it travel before it gets to your plate? What sort of sustainable or local purchases are happening within the cafeteria, for instance? Energy reduction, of course. So, and then we have a very robust data collection process at Practice Green Health. So if you're working within hospitals that may not be part of that network already, I'd encourage you to investigate that.
Thanks, Shanda. That's great. I think we've got several questions that one we can start with that's fairly easy to answer, and was asking if climate change and health is on the state boards, is on nursing board exams. Does either one of you want to take that?
I don't believe it is yet, but we've been working on that through Annie. The education committee out of Annie has been working on that, but to my knowledge, no.
Yeah, I'm not aware either at all. Another question asks specifically about maternal health as a result of climate change, and if there are any specific interventions to alleviate or mitigate some of the side effects from climate change that may occur. I do want to mention that Lauren Underwood out of Illinois, a nurse, has launched a piece of legislation called the Momnibus Act. And this is really specifically to look at Black maternal mortality, but also very specifically to look at climate change. And so for anyone interested in learning more, it gives a great background on how climate change impacts pregnancy, primarily prematurity and low birth weight. There are others, of course, but the Momnibus Act by Lauren Underwood is a great way to start to get some background information and to advocate for healthier public policy. So anything you guys want to add related to that particular question?
Well, Laura, you may be the expert on this as the director of the PACU, but to my understanding, premature labor is linked to higher temperatures. The problems with if people do have respiratory issues and they're subjected to higher ozone days, higher heat days, that can interfere with some of the progress during pregnancy. What I would say generally is about for us as nurses and in treating populations of people, it's important to understand the mechanisms, of course, of these impacts to health, and also specifically in your area, because they do vary a little bit across the nation. On the West Coast, we deal a lot with wildfires and therefore air pollution and the various things that occur related to that. A lot of respiratory and a lot of mental health. Mental health is kind of everywhere, and that too can be an impact during pregnancy. In the Southeast, it may be more exposures to different vectors, also to molds, to flooding, et cetera. So I would just, that's a very general statement, but it's sort of on a continuum, I would say, related to location and severity of the elements that are driving the symptoms. Shanda, would you add something to that?
Just along the lines that, you know, a smaller human is physiologically more vulnerable to a lot of these health impacts that we're talking about. And I don't have expertise in maternal child health, but just thinking, the CDC has this graphic of kind of the top 8 areas where health impacts is impacted by climate change, and whether it's, you know, the air pollution or even like water and food security, things that are more tenuous for a general population are more impactful for smaller humans.
Thank you. And the references that we've included as part of the program planning form has some key documents that I would encourage folks to check into with a lot of chock full of information, also mental health issues that are impacted when people experience extreme weather events. We've got 1 minute left. I'm going to go ahead with the last question, unless Althea, you want us to stop here.
No, you're
Okay.
fine on time. Feel
What
free
is
to
the
go ahead.
biggest barrier? Oh, okay. Okay, good. Thank you, Althea. What is the biggest barrier in getting clinicians on board with conservation and stewardship? Is it cost? Is it a cost in implementing new practices? Is it attitude or misconceptions or lack of understanding about change and direct impact on health? What do you think?
Well, we would both have a lot to say about this, coming from different directions, probably.
I know.
Yeah. You know, because that's really, in a way, both of our life's work. I would almost say, Sandra, you may not see it that way, but I would just offer, because I'm working with clinicians of many professions at this point. My sense is that clinicians are on board. This is not a lack of understanding about climate change and direct impact on health. However, there are differences in empowerment, in priority, in knowing how to make the necessary changes, and sadly, in willingness to advocate. In the Chance survey, which we've mentioned a couple of times, one of our questions that we ask is, how often do you speak with with friends and family, with your professional colleagues, or with elected officials? Friends and family pretty regularly, professional colleagues less so, but you know, now and then. And elected officials, 62% out of our first year's survey said never, and another about 20% said rarely. So I think this is one of the places that we can really push, is in encouraging that powerful voice of clinicians to help advocate for change. But I would say as much internally as well. We need clinicians to be advocating for change in practice. We've had really great successes with many of our physician colleagues in anesthesia, in surgery, in primary care, with our nursing colleagues across the board, because we have such a wide reach, with our pharmacy colleagues. So there's fabulous work underway, but the problem is really immense. So we need lots more people to be working on that. I think the willingness is there. Sometimes the know-how about making change is not there.
And the only other thing that I would add to that is, from a healthcare leadership perspective, is the C-suite on board? Does the board of directors incorporate environmental and climate change as part of their mission work? As Beth said, I agree that the clinical momentum is there. I think the knowledge is certainly building. Can we incorporate terminology for climate and health into job descriptions? Can we include it as part of the overall values of a health system? If the time is built in and the money is behind it, from an organizational leadership perspective, that says volumes. At that point, clinicians won't have to be doing this work on the side, which is what we're seeing now.
Excellent. Well, thank you to you both for a great conversation. Hopefully we've inspired some nurses in the audience to move forward. And I would encourage everyone to take a look at some of the resources and references that we've offered, and to please reach out to any one of us if you have additional questions or want to get started. And I'm going on video to say goodbye, but thank you to everybody, and we'll sign off now. Dr. Hicks.
Great. Thank you all so much, Laura, Beth, and Shanda. We truly appreciate you taking the time with us to speak today about this leadership and advocacy, and how nurses can really get involved in promoting environmental health. And there were definitely a number of other questions we had for you. So we'll probably see if we have those emails and, maybe send them to you. We can forward some answers. So we really appreciate you taking out the time to spend with us today for our leadership and advocacy panel. Thank you again. And now we'll get set to have a break. We'll break for about 10 minutes before we come back with our next presentation. Thank you all. Welcome back, everyone. Thank you all again for joining us today. Our next presenter is Dr. Teddy M. Potter, clinical professor at University of Minnesota School of Nursing. She also serves as the special coordinator of the Doctor of Nursing practice in Health Innovation and Leadership, and she is the director of Planetary Health. Dr. Potter is deeply committed to climate change education, including co-founding Health Professionals for a Healthy Climate, membership in the Alliance of Nurses for Healthy Environments, and membership on the American Academy of Nursing Environment and Public Health Expert Panel. She is a member of the coordinating committee of Columbia University's Global Consortium on Climate Change and Health Education, and a fellow in the Health Institute on the Environment at the University of Minnesota. She chairs Clinicians for Planetary Health, C4PH, and is a member of the steering committee of the Planetary Health Alliance at Harvard. At the University of Minnesota, Dr. Potter designed and co-teaches an interdisciplinary course titled The Global Climate Challenge, Creating an Empowered Movement for Change. In addition, she co-leads a health sciences initiative titled Climate Change and Health, an Interprofessional Response. In 2019, Dr. Potter was appointed the first director of the Planetary Health for the School of Nursing. We are so excited to have her with us today. Welcome, Teddy. Thank you so much.
Thank you so much. And it is an honor to be here, especially today, which is a part of Earth Week. Last April 22nd was Earth Day, and there actually is a whole week dedicated to seeing what we can do about the planet. So thank you for being part of this conversation today. And I do plan on making it a conversation. So at the end, we will, I'll stop sharing the screen and we'll enter a dialogue about where we go from here. So I was asked to talk about how climate change and COVID intersect, but at the same time, I also want to introduce that COVID is not our only issue we're dealing with. As a matter of fact, it's sort of the tip of the iceberg and what we're planning on seeing waves of coming forward unless we get our act together and really understand how to transform our systems. So I'm going to be talking about why this time is so urgent, the health impacts if we don't take action, and what we can do to actually be involved in moving things forward. First of all, I want to acknowledge, at least I'm standing upon the land of the Lakota people in southern Minnesota. The Ojibwe and Anishinaabe people are in northern Minnesota. But wherever you are coming in on the YouTube, I hope you become deeply aware of the indigenous peoples of the land. They understand the land far better than we do, and really have key values and key knowledge that we need to listen deeply to and gain guidance from as we try to heal our systems. Speaking of systems, the Earth is one beautiful, spectacular system. And I have always admired, from the tiniest little grain of sand all the way up to the galaxy, how these patterns work together and how they cycle together. And just the intricacy and the beauty of it. And no matter where you look, this is possible. And I grew up thinking that way. I grew up loving nature. If I could have slept in a glass house, I would have, but it would have been too cold in Minnesota. But I love nature that much. And I watched nature ever since I was a tiny, tiny child. I watched and learned and watched and learned, and nature was my greatest teacher. And I saw how everything was deeply interconnected, this wonderful web of interconnections and mutuality and relationships. And then I got to school, and school teaches you that things are fragmented, and they are in disciplines, and they are in silos. And if you don't believe me, think about elementary school, where maybe you have a history class in the morning, and then the bell rings, and then you have art, and then the bell rings, then you have economics, and the bell rings. And nobody ever came back and said, and this is how economics relates to history. And this is why we need art to help us understand the relationships. Nobody ever pulled us back together. Our education system, at least in the United States, was an education system of workers. It was designed to help us be the most effective and efficient workers in the economy as possible. But it did not necessarily teach us how to be great, good neighbors or how to preserve our homeland. And so I found quite a bit of discordance until I found nursing. And nursing is a wonderful systems thinking profession, as you all know. We look back to our original roots, we did recognize that in order for patients to heal, they need clean water, they need fresh air, they need clean sheets, they need food that was not contaminated, because we didn't have the antibiotics and we didn't have all our fancy technologies. All we had was our wit and our awareness that you needed to have a deep connection to nature in order for our bodies to heal. So nursing has always been walking down this path. We just are going to be talking a little bit more today about what we can do. And these times are urgent, absolutely critically urgent. We are in this little window, and I'm sure you all miss acid-base lectures terribly. But if you look at our acid-base lecture, and the basis of it is people can survive with an acid pH of their blood from 7.35 to 7.45. Teeny tiny little window of acid-base balance. Our entire body works to establish that balance and renew that balance when we get out of place. We're in the same situation right now. We are exceeding that balance in how we relate to the planet. So that idea that you can exceed boundaries is not foreign to nursing. And what signs do we see that we are exceeding our boundaries? Well, one of the first signs, and there have been reports in science for quite some time now talking about climate change. So climate change is nothing new. But our timeline was extended. We really thought, boy, if we take action by 2100, it's looking good, folks. We're going to be able to make it. Then it was, no, we're going to have to be carbon neutral by 2050 if we're really going to pull out of this. And this report from the Intergovernmental Panel on Climate Change in 2018 said, we have about a decade to take action before the worst catastrophic events that we can imagine will be happening and impacting humans. That same year, November, one month later, the fourth National Climate Assessment was released. And this is a national assessment mandated by Congress. And every 4 years, they summarize what's going on with climate change in our nation. And prior to this, we knew that the coasts were impacted, and we knew that there was a tornado alley sort of through the Midwest, and we knew that there was a little risk of expanding wildfires in the West. But this report was a wake-up call to all legislators, because there is not a region that will remain untouched by climate change and its impacts. Then in May of 2019, the United Nations released its biodiversity report. And again, very, very sobering news. We are in the midst of a great extinction, and this is how it impacts humans, because you might think, well, I haven't noticed anything disappearing. Well, you will notice things disappearing when our pollinators become extinct, because our pollinators are responsible for our food systems. So this report really shared the sobering news that we're again exceeding that boundary I talked about, 7.35, 7.45 acid base of blood. We are exceeding the Earth's natural balance. And excuse me, we're seeing evidence of this all over the place. So the decline in birds and other pollinators. This picture over on the right was the death of the last black rhino. Excuse me. The death of the last black rhino and his gamekeeper that was grieving this animal. And some of you have heard me tell this story, but I remember as a child going through the Field Museum in Chicago and standing next to my dad, and we read about the moa bird and the dodo. And I thought, who hunts something to extinction? This is just not possible. Obviously, those people were not very bright, or we know better now. And the sobering news is that we don't. The sobering news is we're allowing our animals and our really many species to go extinct. And then this plaque in the center was erected in 2019 at the base of what was a former glacier in Iceland. And Iceland's full of glaciers, and this was the first glacier to disappear. It was called the OK Glacier. So it was categorized past a glacier state. And it says, a letter to the future. OK is the first Icelandic glacier to lose its status as a glacier. In the next 200 years, all our glaciers are expected to follow the same path. The monument is to acknowledge that we know what is happening and what needs to be done, but only you will know if we did it. And that's the message from the future. Only they will know if we accomplished it. So that's what brings us to this work, because we're seeing signs of the urgency of now almost on a daily basis. So I would say it is a daily basis throughout our news reports. So certainly COVID is a sign of the urgency of now. And the disasters, for those of us that live in the United States, the fires out west this previous summer, where Oregon, Washington, California were burning and creating massive need for people to leave their homes and massive destruction. And then also structural racism. So what's happening to the spirit of humans oftentimes mimics or precedes what we do to the land. So the destruction of our relationships with one another is another sign of the urgency of now. And I like this quote from John Muir: when we try to pick out anything out by itself, we find it hitched to everything else in the universe. And that is nursing through and through, in that we can't separate the patient from what's happening to them. Inside, in the patient, all of what's happening depends on good nutrition, as I said, care, proper turning. You look at our COVID patients, spiritual care, social work care for the families, if there are needs. And then you look at that person once they're no longer a patient, but they're out in the community, and the health of the community. And you look at the health of their region and the health of their schools and their access to transportation and their access to adequate housing. It's all connected. No one piece of this is unimportant. We speak a lot about environmental and social determinants of health, and absolutely all these threads of the web contribute to health. It's just that we have tended to say they're not as important as acute rescue medicine, as acute technologies. And we're saying, look at it, is all part of one web, and we need to be making sure that the entire web is healthy. So as nurses, we understand what multi-system failure looks like. Multi-system failure, as if you've ever worked in an intensive care unit or coronary care unit, is where the systems all start collapsing, and you've got, or somebody's maybe in sepsis situation too. You've got the lungs filling up with fluids, you've got the heart struggling, you've got the kidneys trying to adjust but are starting to fail. Your liver's not reducing toxins the way it should. Maybe the skin is starting to break down if somebody has not been adequately positioned or turned. Neurologically, the person might really be changing. And so many, many, many things, and no one person can solve this. You have to have a team of professionals working together, not with one person telling everybody how to do their work, but everybody bringing the fullness of their capabilities to the scene. So this is where I get I will answer the question that was originally posed to me. And it's like, how does this all connect? So I have a couple scenarios. One is that climate change leads to increased droughts, increased fires, and flooded coastlines. that challenges our habitat. That disrupts our natural habitat. And when our habitat is disrupted, it causes animals, species like us to relocate, and often to be relocated in a same environment where there's pressures of zoonotic diseases developing. So the more we destroy the land, the more we lose biodiversity, the more we risk episodes of zoonotic diseases and pandemics. The experts are already talking about this lining up, this teeing up of these zoonotic events that are going to challenge human health. And the other part is that climate change, as I said, causes droughts, fires, flooded coastlines, which can lead to loss of crops, decreased nutrition, increased susceptibility to new and emerging diseases. So we have a twofold problem here. We've got zoonotic diseases on the rise, and we have impaired immunity also on the rise. And you put those together, and we don't have resistance, and we have new diseases tipping the balance. I also want to share with you, if you're not familiar with it, that the science now shows that some of our major crops that our global population, global human population depends on, wheat and rice, yes, they grow fast in climate change. They're drawing down carbon and they're growing fast, but they're losing their capability to produce fully nutritious products. And so the likelihood of people becoming more malnourished, losing elements that they desperately need, will put people also at risk. So again, everything is connected. Everything is all part of the same whole, the same story. And what I want us to understand is it's not just climate change. We are in a multi-system failure with our planet because we've disrupted Earth's natural systems and are starting to exceed the Earth's natural boundaries. As I mentioned, we're starting to exceed the Earth's natural boundaries. We are starting to have lots and lots of problems all at the same time. So our forests are being cleared to make more way for pasture land so that people can eat more beef. We are seeing, as I said, biodiversity loss, which is extremely rapid. The ocean is acidifying related to the carbon in the atmosphere. The land is becoming desert, and whole groups of people, whole sectors and regions of people are needing to relocate. I want to dispel the myth that means everybody's immigrating to Europe or the United States. They're actually immigrating within their own countries, most of them. But that's putting a huge amount of stress on the infrastructure of cities and other areas in the country. So there's a lot of internal strife that's occurring. Soil, air, and water pollution, and that includes plastics, which are in just about everything right now that we need to look at. So are pharmaceuticals that are in everything right now. We're actually switching, because of our use of fertilizers and other chemicals, we're switching natural biochemical cycles of the planet. Rivers are drying up. Some of the rivers, major rivers in the United States, don't even make it to the ocean. They just kind of dry up before they get there because of our damming and our water and our irrigation processes. Extreme weather events are happening all over the world. Temperatures are on the rise. And this one I want you to be careful of, because if you're living in a state or a region where the temperatures are variable and are altered, but you might be experiencing some cooling, then you get a lot of people saying, see, this isn't real. It's not warming. We're having a colder summers than ever before. So for example, Minnesota, our summers are cooler. Our winters are warmer. If you're just strictly looking at that, you'd say global warming is not real. The planet is warming, causing great variability in our climate all over the planet. But we need to be able as nurses to explain that to people. And then sea level rise everywhere, every coast. And all of these right now are impacting human health. So we don't have to wait till 2030, 2050, 2100. They are happening right now. The impact of all these things, and as they get worse, we're going to see more and more human impact. cardiovascular diseases, respiratory diseases like asthma and COPD, infectious zoonotic diseases, which we talked about, antimicrobial resistance, toxin exposures and drug exposures, heat strokes, certainly, mental health impacts, malnutrition, I talked about that. So it's not just lack of the plants or a lack of access to the foods. The foods themselves are losing their nutritional balance or the nutritional content. This forced displacement and migration, especially internally, which we might see in the United States. If the desert Southwest becomes uninhabitable, we might be seeing massive numbers of people moving north with the climate changes, which can cause civil unrest and trauma. I want to draw attention in particular to the allergies, because a lot of people are noticing that the allergies are really bad this year. A couple things are happening with that. They've been bad for numerous years. As a matter of fact, for at least a decade or a decade and a half, the rise of allergens has increased because of warming weather, because of CO2 increases. There's more proliferation of pollen. But people are outside because of COVID-19. A lot more people are out in nature going for walks, outside, and they're noticing that the allergies are worse. Plus, if you live in a certain place, you might be getting the early impacts of the plants sort of relocating. They're moving to fit to habitats where they can survive and thrive. So you might be seeing the early arrival of plants that are new to your area, and perhaps you do have allergies. So that's something to really keep an eye on. The other one that I want to call attention to is the mental health impacts, in that people whose livelihood or even their spirit depends on a familiarity with the land, and that the land is there, the land is consistent, the land will always take care of you, are finding deep trauma in the loss of the land, of the erosion of what used to be there. And so there's actually a name for it called solastalgia, which is people, the deep loss of a relationship with the land. So in essence, we have mortgaged the health of future generations to realize economic gain right now. And people know that. We know we're making these decisions, but we can't stop ourselves to say, what would it mean? How would I live differently? Excuse me. So the executive report of the Landsat Countdown is done every year. 2019, the executive report had this quote: "The life of every child born today will be profoundly affected by climate change, with populations around the world increasingly facing extremes of weather, food, and water insecurity, changing patterns of infectious disease, and a less certain future. Without accelerated intervention, this new era will come to define the health of people at every stage of their lives." Now, this particular picture means a lot to me. If you just read this quote, you think, okay, and maybe go about your business. But think of the children in your lives. The background in this picture is my son holding my first grandchild. Think about that. Think about your neighborhood children. Think about the children at your places of worship, or your grandchildren, or your children, or perhaps future children, and what things will be like for them. So when I hear a nurse say, "Oh, this really isn't me, I don't have to work on the health of the environment," I pull this quote out and say, yes, you do. Everything these people are going to be experiencing is going to be related to how we're disrupting the environment at this time. So to practice responsibly, I need to be aware of what's happening. I need to get in my canoe and paddle upstream and say, how do we turn this off? How do we shut this down? What's causing this? Why are we in this pattern of destroying our home? That no species destroys their own home. What's happened to us as a species? And the point is, we're living in the Anthropocene, the impact of humans on the Earth right now. Our geological era has now been called the Anthropocene. and that the impact of humans is so significant that this era is named after us. That's a very dubious honor. I'm not so sure that I want to be passing this through. So that brings us to planetary health that I want to talk to you about. And all of you are probably familiar, excuse me, or have studied at different times, public health or eco health or One Health or global health. Planetary health is the umbrella that holds all of that. Plus it holds the humanities, plus it holds space for law and policy and engineering and design thinking and faith communities. So it's a big enough umbrella for all of us to be working under to tackle these problems. Because what we're aiming for right now and what we have to go for right now is a great transition. Everything has to change. Everything has to be redesigned. We can't run around like we've been doing. Putting Band-Aids on a hemorrhage. You know, we see something and we run over and try to fix it. And we see something else, try to run over and fix it. We can't do that anymore. That process is not sustainable. It's burning out our nurses. We can't live with healthcare systems that are not sustainable, with education models that are not sustainable, economic models that are not sustainable. The whole thing needs to be redesigned. How we produce food, how we consume food, how we manufacture, how we consume what's manufactured, excuse me, how we produce energy, what types of energy it is. What are our cities going to look? How are they designed? Do they serve all people? What's our relationship to the land going to look like? What are the stories we tell ourselves? Do we tell ourselves the story that over and over again we're at the top of the heap and it doesn't matter anything, you know, what else happens? Or are we going to share the story, much like the stories of indigenous people, of humans are all connected. We're all connected. No one part of the system, no one member of the ecosystem more than another. So that brings us to, what are nurses doing? I think this is a very, very exciting time to be a nurse, in that we are beginning to understand that caring for the planet, caring for the ecosystem, addressing things like climate change will help prevent some of the worst events that we've seen, such as future pandemics, such as some of the impacts of climate change that I mentioned. So we're at, as I said, at a golden time in history. The way that nurses think, the way that we relate, relationship-based care, relationship-based leadership, systems thinking is now more important than ever. And so it's an incredible time to be a nurse, a very exciting time to be a nurse. And I'd like to share with you one of the interventions that we've started. Nurses Drawdown was born in 2014. I happened to go to People's Climate March in New York City, where 500,000 people were gathered in the streets of New York City to send a very strong message to our national leaders that we have got to address climate change. And I carried a very simple sign that just said, Minnesota Nurse for a Healthy Future. And it was in the shape of Minnesota, and it just said Minnesota Nurses. And I didn't have a stethoscope on or a white lab coat or anything else that identified me as a nurse other than this sign. And what happened next just blew me away, because people came off the sidewalks and wanted to take pictures with me. And they said, the nurses are here, the nurses are here. And I remember thinking, what the heck is this? This is so strange. This just doesn't happen for other people in my group. They're not jumping off the sidewalk to get selfies with other people from Minnesota. So what is this? And I realized that in fact, as we all know, the Gallup poll says for the 20th year in a row, nurses are the most trusted profession in the United States. And so I thought, gee, I wonder if we can leverage that to create real change around climate change. And so I contacted Project Drawdown, which is an organization that produces the science behind the most effective greenhouse solutions. They have wonderful solutions, but they're not going to make much of a difference unless we all start doing them. So I asked him, I said, do you think we could use the trust that people have in nurses and leverage that trust to really teach about these greenhouse gas solutions and how we can participate? And they said, sure, we'll work with the nurses. And Nurses Drawdown was born. I then contacted the Alliance of Nurses for Healthy Environments. Katie Huffling has worked extensively on Nurses Drawdown and giving life to the idea, as have some of the other people on this call, Shanda Demarest and Beth Shank and other leaders from around the world. So that now we have nurses all over the globe participating in this, and nursing organizations such as Sigma Theta Tau, International Council of Nurses, National Student Nurse Association, National Hispanic Nurse Association, and many, many others involved in Nurses Drawdown. So we're on the move. Nurses are on the move. We purposely chose out of all the greenhouse gas solutions, we purposely chose 5 areas to take action. And the reason we chose those is that if people do them, there's the co-benefit of human health improving and the health of the planet. So one of the first initiatives we chose was all around food. And we chose to support and promote plant-based diets. Use of clean cook stoves. This is particularly important in developing nations where a lot of wood is burned to help people, start their stoves. So they need support in obtaining clean fuel versus cutting down forests. And then reducing food waste. That particularly speaks to groups or nations like ours, where we see a lot of waste of food. So we're working on that as nurses. We're also working on mobility and promoting bike infrastructure, walkable cities, and use of mass transit. We know when people are moving more, it benefits their health. We also know when they're using carbon-free methods to get around or reduced methods to get around, the earth benefits as well. The third area is gender equity and education. And people always go, huh? How does that work? Well, when you educate girls, they are able to enter the workforce and they do not have to depend on necessarily a relationship, a partner to support them economically. And so they're able to make their own choices, specifically around procreation and when they choose to have children. And so the family planning and educating girls in cultures where it's appropriate to share that information is a key strategy to drawing down greenhouse gases. The fourth one is looking at our energy. And you might have heard Shanda and Beth talk about the carbon footprint of the healthcare system. And our healthcare system, we don't have a right to point fingers at a lot of other people because our healthcare system is a big part of the problem. So we are, as nurses, calling for an increase in efficiency of our buildings and really promoting clean energy, use of clean energy sources. And finally, we are calling on nurses to be involved in nature-based solutions, taking care of plants and forests, making sure that tropical forests and forests in your own area are preserved, looking at planting trees and being part of the global movement to ensure that we plant trees in all our locations. We also are teaching these sort of values to our young people. And in September, the Lancet published a planetary health pledge. So to move beyond the old Hippocratic Oath to a pledge that is for all professions and all people. And this pledge, we are having our young people and all the health professions say this or adopt this. And so I'm going to play this real quickly. I'm going to do a stop share and then a new share here. So that you can hear this. And I think you should be able to see this now. Is that right? If I could just, are you seeing?
Yes, we can see it.
Okay, great. I'm going to make sure that you see it. Okay, take a listen to this. Hmm. And
I think you just have to
yeah,
unmute it.
there we go.
I solemnly pledge to dedicate my life to the service of humanity and to the protection of natural systems on which human health depends.
The health of people, their communities, and the planet will be my first consideration, and I will maintain the utmost respect for human life, as well as reverence for the diversity of life on Earth.
I will practice my profession with conscience and dignity, and in accordance with good practice, taking into account planetary health values and principles.
To do no harm, I will respect the autonomy and dignity of all persons in adopting an approach to maintaining and creating health, which focuses on prevention of harm to people and planet.
I will respect and honor the trust that is placed in me and leverage this trust to promote knowledge, values, and behaviors that support the health of humans and the planet.
I will actively strive to understand the impact that direct, unconscious, and structural bias may have on my patients, communities, and the planet, and for cultural self-awareness in my duty to serve.
I will advocate for equity and justice by actively addressing environmental, social, and structural determinants of health while protecting the natural systems that underpin a viable planet for future generations.
I will acknowledge and respect diverse sources of knowledge and knowing regarding individual, community, and planetary health, such as from indigenous traditional knowledge systems, while challenging attempts at spreading disinformation that can undermine planetary health.
I will share and expand my knowledge for the benefit of society and the planet. I will also actively promote transdisciplinary, inclusive action to achieve individual, community, and planetary health.
I will attend to my own health and well-being and abilities in order to provide care and serve the community to the highest standards.
I will strive to be a role model for my patients and society by embodying planetary health principles in my own life, acknowledging that this requires maintaining the vitality of our common home.
I will not use my knowledge to violate human rights and civil liberties, even under threat, recognizing that the human right to health necessitates maintaining planetary health.
I make these promises solemnly, freely, and upon my honor. By taking this pledge, I am committing to a vision of personal, community, and planetary health that will enable the diversity of life on our planet to thrive now and in the future.
So I'm going to stop there and just say these are amazing times for nurses, amazing times for us to lead the healing of the planet and the healing of humans and our society. And so I welcome any questions that you might have.
Great. Thank you so much, Teddy. This was a great presentation, very informative. You gave us so much to think about. And I know you mentioned in the beginning about the pandemic and the COVID-19 and how there's so much more, but we did get a question related to that. So the question is, can you direct us to any research that's being done on the impacts of COVID-19 on health due to the climate impacts for both zoonotic and immunity for population health?
What I would do is direct you to the Planetary Health Alliance, which is a warehouse of resources on emerging papers such as this. So I'm not going to pull one out of the stack. I'm going to direct you to, as I said, the Planetary Health Alliance and their resource page. They have articles. They have the most recent research from the Lancet Planetary Health. Lots of really, really good articles about COVID and the relationship to COVID and human health in the Lancet Planetary Health Journal, which has open access articles. But on this site I was describing, so there are articles, there's videos, there's interviews, there's curriculum for courses. everything you need is there. It's sort of like a one-stop shop place.
Great. And I'm just going to ask if you would send that to us, because we are going to send out a resource to all the participants, a list of resources after the event today. So we would definitely be happy to include that for everyone as well. And then another question came in about screening questions. And I guess this is, for nurses seeing patients, thinking about what types of screening questions can nurses use at the clinical level to utilize just even engaging patients about the possible conversation on environmental impacts. So for example, are there any maybe top 3 questions or guidelines that nurses can ask patients as part of a health intake survey?
That is a wonderful question. And I sound like I'm dodging your questions, but I'm trying to bring you to sort of to the place to go. Again, at the Planetary Health Alliance, we have clinicians for planetary health, which is a subgroup of people like us who are interested in this work. And we're just in the process of releasing a seed box full of tools and starting questions and assessment questions that will be out there for clinicians to use. So we're going to be focusing on things like food, mobility, air quality, exposure to toxins, so that we have a very good understanding of the fullness of the people that come to us. Where do they live? What have they potentially been exposed to? What is their job been, their occupation? Have they had any occupational exposures that we need to factor in? Have they come from another part of the country where there's different exposures that they might have had? Have they traveled? Certainly, we've learned to ask that question. Have they traveled recently? But really preparing us to have this as part of the mix of our good standard of practice. So again, I will send out links to you for these resources, because I think you'll have a lot of fun exploring.
That's great. Thank you so much. And then I think one last question we have today is regarding the crop shortage with climate change. We know, there were issues with the crop shortages even before the pandemic hit. So can you explain a little bit about that, how their climate change is impacting the crop shortage, and then we, as a result, have increased pricing of foods and things of that nature?
Sure. So there's a couple of things going on. One is the shortage. So the food crops have actually been destroyed, or the drought has caused it never to reach a harvest, or there's not enough water to feed to nourish the plants. So that's one problem. And then I was mentioning the problem of, it looks like we're raising a bumper crop, but the nutritional value of the plants that we're harvesting is also a problem. It's not going to keep us healthy. And so nurses need to be aware of both of those things going on. I think regionally it's easier to go, look at it. We've had terrible rain this year. We haven't had enough. Our corn crop is down. I need to be prepared that as corn is a staple in a lot of our foods, we might be having people with some food security issues. The other one is more deceiving, because it can look like you've got lots of food, but it's almost a hollow food, a fake food that doesn't have what it totally needs to keep us healthy. So nurses also have to be aware of that. We might need to do some supplementation if people are not getting adequate micronutrients from their food, even though they're eating plenty, even though food scarcity is not an issue. So it's about staying up on this science, and being aware of how this impacts things. And again, the final message is just everything is interconnected. So it's not time for us to say, oh, I'm just doing my work, but I don't have to worry about climate change, or I don't have to worry about environmental degradation. Yes, we do. It's impacting our patients. And so that's the takeaway message. The other last thing I'd like to mention to people is that the Planetary Health Alliance annual meeting is going on right now. It continues now. It started yesterday. Today was the general opening. and it goes till Friday. And it was going to be in Sao Paulo, Brazil, but because of COVID, it's virtual this year, and it is free for everyone to attend. So I will also be sending you, I just go to, I'll put it in the chat while we're waiting, because I'd love to have people, I know today we don't want you to leave this meeting, but tomorrow and Wednesday, Thursday, Friday, please come in. There's over 4,000 people attending, and it'll be really exciting. And this afternoon, later this afternoon, the nurses are talking. So hope you can join us.
Oh, great. That sounds very exciting and very interesting. And just like you said, many of the questions that we had about the resources for nurses in terms of learning how to talk to their patients and, you know, how to bring up these conversations, or even how to identify the climate change impacts that may be relevant, seem like they may be addressed in that information in the Planetary Health Alliance. So thank you so much.
Absolutely.
We really appreciate you taking the time to put this presentation together and spend time sharing this with us during our conference today, Teddy. And this has really been very informative. I see we did put it in the chat for you, so we'll pass that on to everyone. And again, we really appreciate your time. We hope you enjoy, you know, the rest of the conference and this afternoon. And we hope we probably will have you back again. So we look forward to working with you and seeing you again.
And thank you for all you leaders who are taking this seriously. It really does matter.
Thank you so much. All right, everyone. Well, this has really been a great day so far. And we're happy, you know, that all of our presenters have been able to, you know, share such great information today. So thank you so much again, Teddy. Now, our last presentation for today is focused on maternal child health and climate change, and is presented by Melva Craft Blackshear. Dr. Craft Blackshear is a tenured associate professor of nursing with the University of Michigan Flint School of Health Professions and Studies. She has a doctor in nursing practice from Oakland University, and she is the lead faculty for the undergraduate maternity course, as well as the elective Issues in Women's Health. Dr. Craft Blackshear has also served as the project director for the Robert Wood Johnson Foundation grant, New Careers in Nursing. Her primary interest is on women's health, including disease prevention and health promotion. And she is presently conducting a study to enhance clinical competency with maternity nursing students. Dr. Craft Blackshear is a member of the American College of Nurse Midwives, the Association of Women's Health Obstetric and Neonatal Nurses, and the Greater Flint Black Nurses Association. She also serves on numerous advisory boards and committees. Dr. Craft Blackshear's presentation today is pre-recorded, but please feel free to submit your questions in the Q&A tab and with your email address, and we will share them with her, so feel free to pass along and respond. Please welcome Dr. Melva Craft Blackshear.
Good afternoon. My name is Dr. Melva Craft Blackshear, and I'm going to talk to you today about the effects of lead-tainted drinking water and other contaminants on pregnant women, their newborns, and older adults. My interest in this area has arrived from, I'm a nurse midwife and also an associate professor at the University of Michigan Flint campus. And if you can remember, several years ago, Flint, Michigan had a water crisis that was lead-tainted water, and the city, the pregnant women, their newborns, older adults were victims of that contamination. So even though we're looking at several years out of that water crisis, the people there today in Flint, who refer to themselves as Flintstones, still have residual effects from this water crisis. And in other US cities, unfortunately, there's lead problems also, but we'll talk about that. So I'm going to begin. Thank you for being here, and thank you for inviting me to this important conference, because these are very important topics that are part of health education, should be part of health education today. So the objectives of what we're going to talk about today, we're going to identify the dangers of lead and how it relates to maternity care. We're going to demonstrate the importance of pre- and postnatal environment lead assessment. We're going to discuss the effects of lead exposure to the developing fetus and the effects of environmental contaminants, maternal, fetal, and adult health. So let's look at some of the milestones in the history of lead. Lead was first, there's evidence that there were lead mines that date back as far as 6500 BC, and those lead mines were in Turkey. Now, when we look at the US, in 1621 is when we had the first lead mines in the US and the smelting of lead, and that was for the production of lead bullets. In 1904, that's when the US began the first scientific studies that was linking lead-based paint to neurotoxicity in children. 1922, the League of Nations, which was a band of nations after World War I that came together, and their purpose of the League of Nations was to work together for world peace, etc. But they came together and they banned white lead interior paint, and they also eliminated the lead that was in exterior paint. In 1922, the US Public Health Service warned against the use of tetraethyl lead because they found that it caused a serious menace to public health. And a year later, in 3 of the General Motors automotive plants where the people were working with tetraethyl lead, there were 13 to 15 deaths among men working with that lead. And then also over 300 men there suffered from mental health issues because of the tetraethyl lead. 1973, we show that the Lead-Based Paint Poisoning Prevention Act was passed, and that began to eliminating lead paint in the US. Now, this is almost 50 years after the League of Nations banned white lead interior paint. 1986, leaded material banned from the installation and repair of public water systems in residential and non-residential facilities, and this was done by the Safe Drinking Water Act. And in the year 2000, 42 countries phased out lead from petrol. However, other countries, some countries still use leaded gas. And do you remember, as you look at this sign here that says gasoline 23.5, that's 23 cents. And this is a sign that if someone was back in 1970s, I was a teenager in the 1970s, and I can remember seeing gas as cheap as 23 cents. And if you look at the picture below where it says unleaded fuel only, before 1975, we had cars that took leaded gas. And after 1975, when they were putting unleaded gas in cars, all the cars made after that time, unleaded gas only, this symbol was put on the dashboard so people would know that they could only use unleaded gas. When I bought unleaded gas as a teenager in the 1970s, the only reason why I brought it was because unleaded gas was cheaper. I did not understand at that time what was the big deal about lead? And the picture that you see in the top left-hand corner is water that is lead infiltrated that came from fountains in Flint. So let's look at the importance of unleaded gas and leaded gas and the history of that in the US. So the EPA, the Environmental Protection Agency, created unleaded gas engines, and they were ordered by 1975, but they started working on those in 1970. 1971 is when Japan maximized the lead at 0.31 levels. 1972, Japan started using unleaded gas. 1975, all models made in models of cars made in the US had to have catalytic converters. And catalytic converters use the unleaded gas. They had to use unleaded gas because what that did was decrease that lead that was part of the car emission, and the lead would be in the gas that we breathe. So in the air that we breathe, the lead would be in the gas. So in 1975, everyone had that catalytic converter, and all cars at that time that were new cars you had to use unleaded gas. But that was for the new cars. So obviously there were cars that were still present, many cars that use the leaded gas. 1977 to 82, the US scientists showed high levels of lead in children's blood, and they related those high levels of lead to brain damage, high blood pressure, and learning disorders. 1985, lead in gasoline, studies have shown that lead in gasoline may have been responsible for 5,000 deaths from heart attacks, strokes, and other diseases related to hypertension. And as far as since 2011, the only countries that use leaded gas, Afghanistan, Algeria, Iraq, Burma, North Korea, and Yemen. Those are the only countries left on the planet that presently use the leaded gas. So what's the problem with lead? It's a poison. It's a dangerous toxin, and the main target for lead is the central nervous system. Elevated lead levels greater than 10 micrograms per deciliter pose a health threat such as delirium, seizures, stupor, coma, or death. And signs and symptoms of lead toxicity can manifest things like hypertension, behavioral changes, decreased concentration, peripheral neuropathy, ataxia, etc. Some of the symptoms of chronic low lead levels for adults: cognitive decline, hypertension, cardiovascular effects, decline in renal function, and also unfavorable reproductive outcomes. And some of the adverse effects of lead, according to a particular blood lead level range, from 5 to 9 micrograms per deciliter, we can see some possible adverse effects. 10 to 19 micrograms per deciliter, we can start seeing possible spontaneous abortions, reduced newborn birth weight, etc., some possible blood pressure changes. When we move on to 20 micrograms per deciliter, we can see definitely we'll start seeing more spontaneous abortions, decreased birth rate. We may start seeing some of the neurotoxic specific and non-specific symptoms of headaches, fatigue, etc. At that time also, we may start seeing some CNS deficits, of memory and attention deficits. (40 to 79 microgram per deciliter and greater than 80 micrograms per deciliter. We can start seeing some reproductive effects, lower sperm counts, abnormal sperms, hypertension, neuropathy, anemia, abdominal colic, etc. So these are some of the effects that we can see for lead that's in these particular blood ranges. There was a study done looking at the lead levels of people that lived in Flint during the time of the lead crisis, where we had Slutsky and Grossman, two professors. What they did was look at, they took the statistical data of a particular census tract and looked at, during the time of the Flint water crisis, what those lead levels kind of related to as far as fertility and newborn births. What they found was that there was a decrease in fertility rates by 12% among Flint women, an increase in fetal death rates, so an increase in spontaneous abortions by 58%. And infants born during that time were basically 150 grams lighter, and they were born on average of a half a week earlier. So this is just showing what the rate of what was going on in Flint because of the increase in lead and how that affected the women and the newborns there. So when we look at our vulnerable population, we have to think about, as far as concerning lead, we have to think about the nervous system of children and the developing fetus. They are most susceptible to the effects of lead, which is definitely a neurotoxin. And in addition to children and developing fetuses, lead exposure during pregnancy and breastfeeding, it can have a lasting effect on maternal and infants, because the infant's health, what has been found is that lead can cross over the placenta and be found in the developing fetus. So according to the American College of Obstetricians and Gynecology, or ACOG for short, their statement they make about lead in pregnancy is that prenatal lead exposure has known adverse effects on maternal health and infant outcomes across a wide range of maternal blood lead levels. ACOG acknowledges that adverse effects of lead exposure in children and adults are being identified at lower levels of exposure than previously recognized. Let's look at some of those levels. This slide shows a history of lead level policy changes. So let's think about, in 1960, a blood lead level of 60 micrograms per deciliter would have the public health department personnel come and evaluate someone that had a lead level this high. So 60 micrograms per deciliter would trigger the health department unit to come and say, what's going on in this family? Why is this lead level so high? What do we need to evaluate? That's at 60. In 1975, a blood lead level of 30 micrograms per deciliter was identified to be the level that would activate the public health department to evaluate that environment, that family, that group of people. So 15 years prior, it was done for someone at 60 micrograms per deciliter. They learned enough about the neurotoxicity of lead that they said, well, we need to do something sooner. So they changed it in 1975 to 30 micrograms per deciliter. 10 years later, in 1985, they decided that from their data, 26 micrograms per deciliter. We need to identify the people that have lead levels this high and get them into treatment and work with them. In 1991, it changed to 10 micrograms per deciliter. And in 2012, the Advisory Committee on Childhood Lead Poisoning Prevention indicated that the level at that time from the science that they were looking at, 5 micrograms per deciliter. And today, the CDC reference range for value of when to activate the public health system is 5 micrograms per deciliter. So we have come a long way as far as identifying who we need to work with and follow up on because of lead levels. In 1960, it was 60 micrograms per deciliter. Today, it is 5 micrograms per deciliter. And I'm gonna talk about some studies that show even less than 5. They have found detrimental significance with lead levels less than 5. One of the things to remember too is that children and families living in houses built before 1978, particularly in poverty-stricken areas, are at an increased risk because many of those houses still may have lead-based wall paint. So it's important to realize that no national organization recommends that all pregnant women be screened for lead. You know, when a woman goes in for prenatal care, they take their, there's certain tests that they do at a particular time. However, screening for lead is not one of those regular tests that is done. But it's encouraging. During the time of Flint, we were screening people because we knew that there was lead in the Flint water system at that time. But even though if a facility does not automatically screen women for lead, what we suggest is that blood screening questions should be encouraged. Because prenatal identification of someone that has lead exposure could trigger providers, could trigger the nurses, could trigger the social workers in that particular clinic or office to educate the family about appropriate nutrition and removal of those lead sources. So, who's at risk? What's the risk factor for exposure during pregnancy and lactation? And these are some of the things that we want to think about that are listed here on this side for how to, what are the risk factors? You think about people that may have immigrated from other areas where there are higher lead contamination. Think about those countries that we talked about that still use leaded gas. Think about, you want to evaluate where people live. If you think about someone living in a highly dense urban population where they may live next to factories. Maybe there's a factory that makes batteries that use lead, that a highly industrial area. Maybe they're, what is in there? What is their air quality? What's in their air quality? And if you think about lead is something that's in our environment. It could be in the soil. So if they're living around a large industry, you think about someone that maybe uses, that makes ceramic pottery, lead glazed ceramic pottery. That could be someone that is at risk for having exposure to lead, particularly if they're pregnant now. Someone that's had a question to ask, someone that's had a history of having a high lead level. Someone, if there's contaminated drinking water that has been evaluated around where that person is living. But these are some risk factors that people can have that, that you may want to further evaluate and do a lead testing if this person appears in a prenatal clinic or primary care clinic. And some of the things also, someone that uses, they say they use folk medicine or they use complementary substances, and you're not sure of what they are. Some of those substances may have lead in them. They may come from other countries. So that's something else to assess to determine if you need to do a lead level on them. So we absorb lead from the GI tract, from our skin, from respiratory system. It could be in the air, it could be in the soil. And the thing about lead is that it binds to our hemoglobin, and it has a half-life of 1 month in the blood. So if someone was exposed to lead, it would be in their blood for a month, but then it can be in the bone for 20 to 30 years. 90% of lead is incorporated in the bone. Now, what happens, bone demineralization, and that is something that happens during pregnancy, can happen during pregnancy or during lactation. But what that does, it enhances the lead from the bone, and the lead is back into the blood, and lead can cross the placenta and expose the fetus. Okay, so we're talking about lead leaving the maternal bone, crossing the placenta, and going into the fetus, because it does this through passive diffusion, crosses the placenta into the fetus, and lead has been detected in the fetal brain in the first trimester. So think about that 3-year-old girl that was in Flint, Michigan, that had a lead level of 5. And let's say her mom decides after a year dealing with bottled water and, the government there not really taking care of things fast enough, she decides, I'm moving. So she leaves the state of Michigan and she moves out to California. So she's 20 years old now. She started college, and she's finished college, and she's married, and she's pregnant, okay? And what has happened, no one asked her anything about, she's been away from Flint, Michigan for so long, she may have forgotten she lived here. She may have forgotten about the Flint water crisis, but she's pregnant. And let's say she's not eating as well as she should. She's not taking in as much calcium as she should. She's not taking in as much iron as she should. So what happens is that the lead that was in her body when she was 3 years old that went into her bones. Now that she's in a state of pregnancy and she's not taking in as much calcium as she should, as much iron as she should, she has some bone demineralization. That lead leaches out of her bones. No one checks her for this, and it crosses the placenta and it affects her fetus. This is something that can happen because of that previous exposure when she was 3 years old. So here are some screening questions that could be asked to pregnant women and lactating women about their previous lead exposure. And if these things were asked to that young woman that is now pregnant in California, but that came from Flint, who was exposed to lead at age 3, this could probably, help her to remember, oh yeah, I remember I was exposed to lead when I was 3 years old. And they could do a blood lead level on her to see what the situation is, and they can monitor her and make sure that she has an appropriate amount of calcium, iron, zinc, vitamin C, and D and E, so she does not transfer any lead to her unborn child. So these are some of the things that can be used for screening questions to decide who also may need to have a blood lead level. This slide is just indicating if a mom has a particular blood lead level and what the level is as far as the microgram per deciliter, and how often they need to have follow-up tests to make sure that their levels are safe for their developing children. Here's some research support, and basically if you look at some of the numbers here, median maternal lead level 3.2, the umbilical cord level 2.52. Also, we're looking at Lee and al. Who had a pilot study of findings of 362 umbilical cords that had blood lead levels as high as 3.92 or as low as 1.89 microgram per deciliters. So we're talking about low numbers here. However, you still see where there are deficits in psychomotor and mental development with these lower blood lead levels. And if you remember in 1960, how high those levels were, that the public health system went out and followed people up. But we're looking at levels and research that show levels as low as 1.8 now, that's 1.89, that still shows a deficit in psychomotor and mental development with these low blood levels. So that goes to tell you that no lead level is a safe level. Additional research that supports the neurotoxicity of lead, even at low levels. One study in Needleman and al., adolescents between the ages of 12 to 18 were found guilty of committing a delinquent act, were 4 times more likely to have elevated bone lead concentrations in their tibia comparable to non-delinquent groups. So you talk about that. One of the things that they found with the neurotoxicity was the aggression that some people had, and they're referring that may be related to lead. Another test, another study, lead levels below 5 micrograms per deciliter, associated with more than a 2-fold increased risk of diagnosis of ADHD when compared to children that had no detectable lead levels. So that neurotoxicity, what is going on, with the lead? this is why and then when we look at our elderly, and if you remember back a few slides, we talked about how lead is deposited into the bone. So lead can accumulates over a lifetime and produces negative cognitive consequences in the elderly. So if you think about the elderly and lead accumulating in a lifetime, lead stored in the bone, that is, we talked about it being released during pregnancy, released during lactation, but then also it's released during osteoporosis, because osteoporosis is a form of decalcification, and lead that that is stored in the bone during when someone's elder and if they become osteoporosis, that lead is leaching out of the bones. And then studies have shown that that lead can cause lead exposure early in life produces latent cognitive effects that emerge later and that can be emerged as a form of Alzheimer's disease. In addition, people that had occupational exposure, working with lead and copper or lead and iron, particularly maybe factory workers, they had an increased risk for Parkinson's disease was twofold compared to people that did not work in these areas. So Parkinson's disease, which is a neurological disease, could be because of a lead. And there was a study recently done looking at the drinking water in California, and they compared drinking water contaminants and how that caused hypertensive disorders in pregnancy. So they saw an increase in hypertensive disorders, including preeclampsia and eclampsia, associated with cadmium found in the water, lead, trialomethane, I can't pronounce all of these, hexavalent chromium in the drinking water in California. So, and when we talk about preeclampsia and eclampsia in pregnancy and hypertension, this is detrimental and life-threatening to the mother and also to the newborn. And this is what we're getting, and this is in our water. In 2011, the Congress passed the lead copper rule, and the lead copper rule changed the lead was revised. Something was at 8% of lead. If 8% of lead was in it, it was considered lead free. However, that was reduced to 0.23%, and that came from the Lead Copper Rule Act that was passed in Congress in 2011. Now, the stipulation of that rule was that lead had to be less than 15 parts per billion and copper concentrations less than 1.3 parts per billion in at least 10 and more than 10 water samples in order to say that they did not have to use anti-corrosives material to treat the water system. So in other words, if you lived in a city that was less than 50,000 people and they sampled 10% of the water, and 10% of the water was showed that there was greater than 15 parts per billion of lead in it, then they would have to use an anti-corrosive in the system for your drinking water to be good to drink. However, if there was less than 15 parts per billion of lead in the system, then they did not have to use anti-corrosives for the water treatment system. However, if you lived in a city where there were greater than 50,000 people living in the city, it didn't matter. You didn't have to do any samples. You just had to add the anti-corrosive materials to the water treatment. However, for clients that you may have that live in rural areas where the water system, they have, let's say, private wells, and if those water systems treat less than, they're used by less than 25 people, there's no regulation under the Safe Drinking Water Act at all, where the city has to test that water. Now, this is what happened in Flint. Flint is a city in Michigan that had more than 50,000 people, and they should have used anti-corrosive materials automatically. However, they did not. And because they did not, they had the leaching of lead from those pipes. Now, the State of the Industry report by the American Water Works Association indicates that our underground water system is basically near the end or has surpassed the useful life. And it's very important for that we replace lead and aging pipes nationally to decrease and eliminate lead exposure in our drinking water. The needs survey, the 2015 drinking water needs survey indicated, as you see, the $472 billion of investment that is needed for our water system to provide clean, safe drinking water. After the water crisis in Flint, Michigan was broadcasted, time and time again, you hear about other cities, other states where they have problems with their water system and problems with lead. So it's really important. We have an old system, and it will take billions to replace, to start to replace some of the hardware that's in our system. However, this is one of the mandates that the Biden-Harris administration is talking about doing to create jobs today. But this is something that we definitely need to get rid of some of these older pipes and to decrease our risk of drinking contaminated water. So postnatally, women, if they're not screened prenatally, or if they come in late for prenatal care, it's encouraged that to do the same screening to see if they've been exposed, and if they answer positively to some of those questions, for them to be screened, particularly also if they plan to breastfeed. If they plan to breastfeed, and if they have a blood lead level of 40 micrograms per deciliter, they're encouraged, even though breastfeeding is the greatest thing, they are encouraged not to breastfeed until they bring that blood level down. One of the ways, you talk about increasing their diet, calcium supplementation, iron, zinc, vitamin C, etc. And some of the studies that are listed here found that when pregnant women had higher iron levels, if they had calcium intake, adequate calcium intake of about 1,200 milligrams of calcium, how that helps to lower that lead level and lowering the lead breast milk level. This is a chart that indicates when, and some of the things that we did in Flint is when they birthed their neonates, We looked at cord lead blood level, and also the neonate lead blood level, and kind of follow the public health guidelines of what to do depending on how often to test, and also how to treat depending on what the infant's blood lead levels were. So the nursing implications for this is to assess our clients. You know, we have environmental concerns today, and to assess our clients for lead and other contaminations that they may be exposed to. This should be part of our general intake, prenatal, postnatal, and primary care visits. Adopting a questionnaire to assess for these things. We assess, you know, do you have a headache? Are you taking your medicine, high blood pressure, etc. But we should also remember, we hear so much today about the social determinants of health. We need to assess about their home environment, their nutritional environment, etc. These are things that we need to also assess. If someone's pregnant, definitely we want to do this first prenatal visit, follow-up visits, and also preconceptual counseling visits, you know, if they're thinking about getting pregnancy, to get them in the best, healthiest state possible. So clients from areas that have been publicly announced that there is lead that is in their drinking water, or an abundance of lead in their soils, we want to make sure that the nurses working with their health departments can offer education, nutritional support, providing emotional support to allay anxiety. There was a lot of anxiety I remember firsthand in the city of Flint, and then working with interprofessional teams, nurses, obstetricians, pediatricians, primary care physicians, health educators, social workers, etc., to work with the communities to help the clientele in the communities to get to a healthy state. And to always remember that primary prevention is always crucial because the effect of lead exposure we see can last a lifetime and is believed to be irreversible. We have to remember, I truly believe, and hopefully most of you will, that clean water is a human right for all of us. So hopefully with the new administration, we can get to a point where we're cleaning up and restructuring our infrastructure of our pipes and mains, etc. And Lauren Underwood, one of the congresswomen from Illinois, she's introduced a Climate and Health Protection Act, because even though some people don't want to believe it, but there is a climate change that's going on. So we need to, living in a safe, healthy environment is a human right and is a right for all US citizens. And this was a the cover of Time magazine during the Flint water crisis. This, and I just always have to show this because this was the city. I don't live in Flint, but I work in Flint at the University of Michigan, Flint, and this pulled at my, and still does, at my heartstrings, how a community was poisoned and it did not have to happen. And and it's part of all of our jobs as health providers to assess our patients, to assess our clients, and to talk to them about the social determinants of health, and work with them so they're eating healthy, being healthy, playing healthy, and living in a healthy environment. As US citizens, we all deserve this. And that's just the timeline and our references. Thank you.
Thank you, Melva Craft Blackshear. We are so appreciative to Dr. Blackshear for that great presentation on maternal and child health and climate change, including the Flint, Michigan water crisis. That was a very detailed presentation that provided a lot of valuable information. So we are sure everyone really gained a lot of valuable knowledge through that. And at this point, we are coming down to the end of our conference. So again, we'd like to thank all of you for joining us today. And thank you to Columbia University School of Nursing for providing the CNE credits for our event today. For those of you participating that would like to receive CNE credits, remember that an email link with further instructions will be sent to all attendees following today's presentations. Columbia University School of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. So we're grateful to them for providing that service for us today. We'd also like to remind everyone to please remember to follow us on social media and tag us on your posts with the hashtag Jonas Impact. And we want to give a special thank you to everyone who participated in today's discussion. We hope this information has been valuable and that you were inspired to increase your leadership and advocacy for environmental health and climate change through nursing. We are sure you've gained a wealth of knowledge and valuable resources. So we thank all of our presenters today, all of you participating for their, we thank you for the presenters for their time and expertise. We also like to thank our planning committee, all of those experts that assisted us in planning for today. This has truly been a pleasure having all of you with us today. Again, we thank also the Jonas family and the Jonas Philanthropies organization for their contributions and support and for investing in nursing education and important health matters across all populations. Thank you again for joining us today, everyone, and we hope that you stay safe and stay well. Goodbye.